have Dr. Roshini, Senior Consultant in Glaucoma Service, Chaitanya Hospital, Trivandrum, for her talk on retinal nerve fiber layer analysis.
Thank you, Vijay ma'am. Thank you, Sarda ma'am, Team Kotem, my teachers, for this opportunity. Let's see role of retinal nerve fiber layer analysis in glaucoma diagnosis. So why RNFL analysis? We all know structural changes may precede perimetric changes, and RNFL analysis is extremely sensitive for detecting pre-perimetric glaucoma suspects, excluding physiological cupping, and is useful for monitoring disease progression as well. So clinically, RNFL is evaluated under the slit lamp using the 90D lens under the red-free filter. Normally, it is seen as alternating dark and bright striations. When there is RNFL loss, there will be diffuse loss or slits or wedge defects. RNFL analysis can be done by scanning laser polarimetry or OCT. OCT is preferred. So OCT RNFL evaluates the structural damage as I mentioned, and it's non-invasive, objective, and rapid, and gives a quantitative measurement of the thickness of the RNFL and compares with the normative database also. Principle is optical interferometry, but newer OCT machines uses a spectrometer. Time domain OCT came first, followed by the spectral domain OCT, and step source OCT is the newer addition. Spectral domain OCT is the device most commonly used in clinical practice now, and the commonly used devices are the Spectralis and the Cirrus. The scanning protocols and segmentation algorithms are different, so the measurements are not easily interchangeable. And each device has its own age-matched normative database, and the age range in Cirrus machine is 18 to 84 years, and the refractive error is -12 to +8 diopter, and in Spectralis it is -6 and +6, and an astigmatism of 2 diopters. The peripapillary RNFL thickness, as we all know, is the most popular OCT parameter used, and Spectralis measures this directly with a 3.46 mm diameter circular scan centered on the optidisc. And the Cirrus, this measurement is generated from a 6 mm cube scan centered on the optidisc. Interpretation, the general rules, RNFL thickness display in the printout is both quantitative as well as color coded. Green is normal, yellow is borderline, and red is abnormal. White is seen when there is thick RNFL, and also when the normative database is not available. Gray is also indicated when the normative database is not available. Our average RNFL thickness and the inferior quadrant thickness are the most clinically relevant RNFL parameters, and a difference of more than 9 micrometer in average RNFL thickness between two eyes is suggestive of early glaucomatous damage. And RNFL thickness also follows the ISNT rule, and violation of this can be indicative of glaucoma. But if there is a nasal and temporal quadrant thinning, we have to think of the possibility of non-glaucomatous optic neuropathy also. So this is a Spectralis RNFL analysis printout. A good printout will have a good quality scan will have a good disc picture and RNFL displayed clearly. And the printout gives a BMO centered OCT scan of the RNFL, which is seen by these bright green circles. And this circle is an unrolled and gives a horizontal OCT scan, which gives the circumpapillary RNFL in a single shot. And this circumpapillary RNFL is displayed in a TSNIT order, generating the TSNIT thickness profile, which has a double hump pattern because of the superior and inferior RNFL being the thickest. So RNFL classification charts in the Spectralis gives the average RNFL thickness for the global 360 degrees for the 4 quadrants as well as additional 4 sectors, and the measurements are displayed in a color coded manner, with green being within normal limits, yellow borderline, and red being outside normal limits. So this is a Cirrus printout, and the quality or signal strength of more than 6 is good, and the key parameters are displayed in a table, and which gives the average RNFL thickness of both eyes, RNFL symmetry between both eyes, and optic nerve head data also. So other features of the Cirrus printout are the RNFL thickness map, which has an hourglass pattern and is color coded. Blue is thinnest. The RNFL deviation map, which is based on which is compared with the normative database, again color coded, with the warm colors being the thin RNFL. Also gives the neuroretinal rim thickness profile, the TSNIT profile, the RNFL quadrant, as well as the clock over thickness, which is matched to the normative database, the horizontal and vertical B scans, and the RNFL calculation circle, which gives the boundaries of the RNFL segmentation also. Though widely used, our OCT is not free from artifacts or pitfalls. Small optic discs, long axle length, and older age are associated with thinner RNFL, and RNFL thinning is also seen in non-glaucomatous optic neuropathy. So, clinical correlation is very important. A good medical history, clinical examination, photographs of the optic nerve head, visual field gives a good diagnostic yield along with the OCT RNFL. So, few artifacts, motion artifacts and blink artifacts are common. Both cause loss of data. And RNFL touching the floor is also artifactual because the thickness less than 40 microns is artifactual. And segmentation errors are also common, which can be seen from the OCT scan. So another artifact is decentration of the calculation circle. We can see the calculation circle is descended here. When corrected, the RNFL thickness comes out normal. Other artifacts are floater artifacts and machine-related artifacts like smudges. OCT printouts in myopia should always be read with caution because normative data is not available for more than -12 diopter, and peripapillary atrophy and tilted disc can cause pseudo-thinning of the RNFL as in this case. And floor effect, we all know as the glaucoma advances, RNFL measurement continues to decrease, but it does not go to zero because of the floor effect. The reason being the architectural support by the Muller cells, astroglaya, and the blood vessels. And in spectralis, the average RNFL floor values range from 49.2, and in cirrus it is 57 microns. But progression can still occur, but cannot be detected by the RNFL OCT. So we should consider macular OCT or 10-2 for progression advanced glaucoma. Green disease occurs when small focal errors, small focal areas of damage are shown up as green because the machine averages the thickness in that particular sector. And red disease occurs as the assessments are made by the computer software based on normative database. Measurements tend to fall outside normal range in certain cases like myopia and non-glaucomatous causes of RNFL thinning. Like in this case, this is a normal disc and normal visual field, but the OCT RNFL is showing an abnormal area. A few words on macular ganglion cell analysis. It is also possible with the OCT because the macular inner retinal layer is less affected than the peripapillary RNFL with large areas of peripapillary atrophy or high myopia. And in myopia, this is helpful for diagnosis of early glaucoma. And finally, progression analysis. This is also available with the cirrus. This gives both event and trend-based comparison and differences of 7 micrometer or more for superior and inferior quadrants or more than 4 micrometer for average RNFL scans. Average RNFL between the scans is outside normal. Thank you.
Thank you, Roshini, for your excellent talk. Now the session is open for discussion. OCT RNFL may play an important role in the diagnosis and management of glaucoma and should be a part of an optic disc examination also.